Hello. How are you all? Bless you. All right. So how is everybody today? Everybody good? Awake? Somewhat awake?
Not very awake.
Not very awake? Okay. All right. Well, it's funny. My cat let me sleep till 4 today, which was unusual. So I think she always likes to get me up to make sure I'm ahead of my work I'm supposed to be doing or whatever on the computer. Because as soon as I come in here and start working, she sleeps. It's like a strange little thing. All right. So I know you probably have been thinking about it all week. I wonder what pictures he's going to show us cancer wise to finish up. And of course, I save the best for last. Uh, some of them are worse than others, but that's okay. So let's show you. This is a nice little squamous cell. It could, I don't have a history on this one, but it could have originated extraorally as a skin cancer and went intraorally, or it could have gone intraorally and worked its way out. But it basically is a through and through. You could stick your finger in to the person's mouth through that lesion. So quite big. And it's amazing that when it gets that large, why the person's still alive. This is a case that I actually saw when I was in public health. I've seen a couple squamous cells, and it by far is the worst one that I had seen. 50, I think he was 52 years old. His name was Henchy Cross. And it's funny, you always remember your first patients or your worst patients. I still remember my first patient in dental school. His name was Mr. Brewster. Mr. Brewster had acromegalia, which we'll talk about later. So whenever I, talk about acromegaly, I still remember him. And gosh, that's so many years ago, it's not even funny. This Henchy Cross came in, his daughter brought him in, and he had pain in the mouth. He couldn't really eat or drink. He was having so much pain. Well, this is when I first saw him, and that white area that you see on that is dead tissue. When he came in the operatory, before I even got in the room, I could smell the issue, and it smelled like dead tissue. What you see over on this, let me get my pointer here, maybe. Dang, pointer never behaves. There we go. I just learned a trick. This area is exophytic. It's firm. You could palpate this guy's underside, and it was all rock hard. We looked at this guy, and you can't tell him he's got cancer without a biopsy. This tooth here is mobile. So when we saw this guy, his history was a smoker and a drinker. He drank a fifth of whiskey a day, and he probably smoked 2 packs of cigarettes a day. So when we got him to the oral surgeon took a biopsy, and within a week, look at the size of this to the size of this. It had grown so much in 1 week. It was ridiculous. His whole lower jaw was tumorous. His lower lip, rock hard, floor of the mouth, rock hard, submental, rock hard. I mean, it was just ridiculous. General surgeon, oral surgeon, refer this to a general surgeon. He's like, this is big. The general surgeon wanted to remove his lower face. So just imagine commissure's back. This is all gone. Realistically, would he survive the surgery? No, he wouldn't survive the surgery. So what they did was irradiate it to try to shrink and kill the tumor. Well, it did. It shrunk it down dramatically, but he ended up dying within 4 or 5 months after this. So pretty devastating cancer, to say the least. And let's see. Oh, there we go. This is a homeless man. Homeless man comes in. He basically is having problems eating and all that kind of stuff. 2 years before, he was diagnosed with squamous cell and decided not to have any treatment done. This is what it looks like after they've cleaned it up a little. So what you're seeing is basically what is left of the maxilla is the teeth facing down. So this is maxilla. This is quadrant 4, and quadrant 3 kind of gone. And you see this type odds and ends, these are maggots. So he basically had a nice little infection going along with a squamous cell. And it's amazing that he is actually still alive with the size of this, because you know it's metastatic. But you do notice that he is on a breathing tube. So he didn't live very much longer after that as well. So that is what you've been waiting for. Quite exciting, isn't it? Well, yeah, something like that. Okay. If you're not awake, that now definitely will get you somewhat awake. So my next question is, did you get to see the pink, the flaming box elder teeth? Did she wear all 6 of them? Or she just bring them in and show them to you? Were they exciting looking? Yeah, come on, you're not as excited.
He showed them to us in a class.
Okay. Don't they look good?
Beautiful. I like it.
It's a weird wood. So, hopefully that'll motivate you. And actually, we're doing pretty good today. I see I have everybody but 2. So that's actually pretty good. I like that. So, all right. So let's go ahead and we will continue. So we're going to talk about white lesions today. When we talk about white lesions, basically we're talking about leukoplakic lesions. It always sounds more impressive when we use the term leukoplakia or leukoplakic. But you may see write-ups that say, hey, patient presents with a white lesion. Okay, so nothing wrong with doing that. When we use the term leukoplakia, if we see a leukoplakic lesion in the mouth, if it is isolated, meaning let's say we see we've got a little area and we see it right like that, right? If it's localized or isolated, most common we're going to see trauma. So something has caused that lesion. Chronic rubbing is the perfect example, all right? The other thing is it has a potential for being neoplastic, so a cancer. So it's localized in one area. So we're talking about something that is unilateral more so, but you can find a bilateral traumatic lesion, but that's typically what we see with it. All right, some sort of trauma is common. When we see something that's more generalized, examples of that would be, have you heard the term leukoedemia? All right, leukoedemia is more of a generalized type of scenario. You're going to see it involved bilaterally on the buccal mucosa. All right, that is more hereditary. So bigger type involvement, we're seeing systemic, immunologic, or hereditary. So that's a general rule. And of course, again, you can always find variations of that. The rule that we try to do, if we see something that's in the mouth that is white, all right, we say it's a leukoplakia. If we don't know why it's there, we call it an idiopathic leukoplakic lesion or idiopathic leukoplakia. And that is defined as a white patch or plaque that we can't figure out what to call it yet. Okay. One of the things with leukoplakias, you'll notice that I put in this definition that it cannot be rubbed off. That's what we do with white lesions. We try to rub it off to see what it tells us. Okay. Our rule of thumb is I don't want to call something a leukoplakia. I want to call it what it is. So it may be, I may say, okay, oh, that's a car driving down the road. Well, look how many cars drive down the road. If I say that is a 66 VW Beetle, it specifically identifies the car. Okay. And that's what we want to do with an idiopathic leukoplakia. We want to identify it. So when we look at leukoplakic lesions, if we look at tissue that is normal, normal tissue can become hyperkeratotic or can undergo hyperkeratosis. Hyperkeratosis is excessive keratin layer. The outer layer of tissue becomes thicker. So if you have some sort of trauma, that tissue responds by change. Okay. What happens if we remove the chronic trauma? The tissue goes back to normal. All right. So those two-way arrows are telling you that we can have normal tissue. It can become hyperkeratotic or thickened, and it can go back to normal, especially if we remove what's causing it. In the same sense, we can have a tissue that is hyperkeratotic, and if it's undergoing the right circumstances or conditions, those cells may become dysplastic, all right, or exhibit dysplasia, abnormality. Now, we can remove anything that's causing that, and it can go and reverse back. What we see, though, is if you have a tissue that is undergoing dysplasia abnormality of the cell types, it can progress in a one-way direction to early cancer. That's what carcinoma in situ is. So you can have surface tissue that is kind of like a pre-malignant or dysplasia. It can become cancerous, and it starts as carcinoma in situ, meaning the cancer is in the epithelium. If you leave that lesion growing, you don't identify it, and you leave it, it becomes invasive carcinoma. You will notice that there's one-way directional arrows. When something is diagnosed as a cancer or carcinoma, it is not possible to revert back to normal. So that's just tissue changes. So if we see a localized white lesion, we look at the location, we describe it, we try to determine, can something cause this lesion to present? Could trauma? Yeah, you could traumatize. You'll be amazed what people do to their tissues. And then, of course, we want to look at location, size, lymphadenopathy. Is it unilateral, bilateral? Palpation. Is it firm, soft, indurated? Okay. Our object is we don't want to just say, hey, this is a leukoplakic lesion, and we leave it at that. That's not what we want. We want to evaluate it further. This is a pretty extensive lesion. If you look at the lesion, it is going here. And then when you look up here, it's a little different shaping. So something like this is a pretty good concern for you as a practitioner. And of course, we're going to check the other side just to see. So when we have a generic leukoplakic lesion, if we don't know what it is, we can't say it is like that car. If I sit there and say, okay, it's a car, and I say, all right, well, I just know it's a car. I have to, if I had to biopsy the car, and when I biopsy it, it tells me it is a 66 VW Beetle. All right. It's telling me specifically what it is. Well, when we look at a leukoplakic lesion, like the two I just showed you, 80% of the time when I take a biopsy, it's actually benign. I may not know what caused it, but biopsy report tells me it has a high chance of being a benign condition, even though I don't know what it is. In 12% of the cases, when I biopsy it, I don't have a clue what it is. I send it for biopsy. 12%, it's telling me something's wrong with those cells. I'm going to start really monitoring it. And of course, 8%, it is telling me it's cancer. So unexplained white lesions, when they're biopsied, they have a higher percent chance that they are okay. When we talk about red lesions, huge difference. There's a lot of cancerous lesions that when they biopsy unexplained red lesion, they're cancerous. So unexplained white lesions have a higher chance of not being cancer once we get the biopsy report back. So we look at something that's white in the mouth. There's actually 3 different reasons why something is, let's see, why something is white. Some of the most common things: thickened tissue. Thickened tissue, think about your tissue should be pink in color. But if you thicken it by chronic rubbing, all right, just like a callus, it's going to change the color to be white in color per se. Debris is another thing that can make something white. Think about plaque. You all probably haven't seen horrible cases of plaque. Well, you can have plaque covering tooth and tissue. But what do you know about debris? Debris, you can wipe it off. And next thing you know, you don't have it. It's over what you wiped. Really, the third reason, reduced blood supply. We don't really see that in the oral cavity, but think about if you have a blood vessel and you push, everything blanches distal to where you pushed, but that could whiten the tissue. So when we look at thickened epithelium, we take a white lesion after looking at it and getting what we want. We pick up a piece of 2x2 gauze. We wipe the surface of the lesion. If the surface does not change or wipe off onto the gauze, it's telling us it's thickened tissue. The tissue has done a change, okay? So when we look at debris, debris will always wipe off. I got to post a picture. I had a girl come in when I talk about debris. She had something on, she went to the ER for this. And I don't know, or she was in the hospital, went to the ER and all this, but she came in to me and she's like, something's wrong with my tooth. She ended up having dried bread on 8 and 9. And she she literally could not brush it off. I had to take a Cavitron to actually get it off. But when I got it off, I was like, this looks like bread. And it had to be bread. It was rock hard dry on her tooth, but it wiped right off. And that's what, when you look at debris, you can see somebody that has so much plaque, you wipe it off and it's telling you it's something that is temporarily on the surface. All right. So that's what we do with white lesions. Other diagnostic tools that we do with white lesions, lesion history. The history, you can sit there and say, okay, what did you do? I've seen some strange things. I remember a guy that rinsed his mouth out with kerosene. He actually, yeah, you're like, what? That was what he believed would get rid of a toothache. Well, kerosene in the mouth does not do well, to say the least, but it changed oral tissues. And I'm like, what are you doing in there? All right. So that kind of tells me the history. The other thing is, do you do any weird oral habits? Some of you all I know chew your cheeks. Either maybe they taste good, I don't know, but you do it as a nervous habit. I've seen students do strange things while they're taking tests. I used to have this one that would play with her hair, and then she had this curl, just one hair, because when she's taking her test, she's doing this. I've seen some doing this. They're thinking, and that's their oral habit. Well, it changes tissues. And the other thing you can always do is ask, or if you have other family members in your practice, look and see what they have, because some genetics comes into play. So we're going to look at conditions as far as hereditary. Okay, these are genetics. And when you look at genetics, it's telling you tissue changes because it's a genetic change. It's something that's normal for that person because somebody else has it. This is one that they probably taught you when you look in there doing your intraoral examination, leukodemia. Leukodemia is a variation of the buccal mucosa. It's normal for that patient. It's more commonly found in dark-skinned individuals. 92% of blacks have it. Whereas, if you see it in somebody that's white, yeah, they can have it, but dramatically less common to see. So it's just normal for them. Typically with leukodemia, it's going to be bilateral. It almost looks like they have placed skim milk on the top of the surface. All right. So if you take skim milk and place it on a bright table, you can kind of see the bright table underneath, but there's a film on the top. That's kind of what it looks like. As the person gets older, the lesion becomes more pronounced. So you can find this in children, but it's not going to be a huge amount. So when you look at this, it looks like a white film on top of the tissue. You check both sides, you're going to see it's bilateral. This is a little bit thicker. Okay. And again, you look at the cheek. If you see something bilateral, it's definitely less of an issue. Unilateral, we have higher concerns. So this is a good case of leukodemia. It's got a good thickness on that tissue surface. And again, it's a normal finding for that patient. So my next question, what is this?
Is it the parotid gland?
Stenson's duct. Yeah, good. That's Stenson's duct. Wonderful. Now, I won't ask you, okay, what type of secretions come from it or what percentages. We'll behave somewhat today, somewhat. How you diagnose leukodemia is stretched cheek. If you think there's a covering, when you stretch it, the lesion will, what we call, dissipate. It will, a lot of it will go away. And in some cases, it will actually disappear. So when you release the cheek back to normal, it comes back. All right. So this is before, and this is stretched. You can see the difference. Now down here, it's telling you it's pretty heavy leukodemia. It may not go all the way away. And that's a normal variation. And that's how you diagnose it. Stretching instead of wiping. It's kind of changing in the tissue surface. Okay, normal finding out. This is something that we always have to tell you about. I can honestly say I've never seen a case of it. It's pretty rare, but for some odd reasons, the boards like you to know about it because it resembles leukodemia. It tends to be deeper folds of tissue. And when you stretch this person's cheek like leukodemia, you get no changes because it is much, much thicker. What you also need to be familiar with, you may hear the term Cannon's disease. That is the person that found it. They found it and they found it in specific type of population. So they called it Cannon's disease. I had always wished I'd found something orally because then we'd have, Foster's disease or something like that, but no such luck. Everything has been already claimed. But this is an example of Cannon's disease or white sponge nevus. It looks like a thick version of leukodemia. It is the same thing bilateral. Family members have it. That it's kind of passed down hereditarily, but can't say that you'll ever see it. When I look at this, I think cheek biting, first of all, but history tells us, and they probably have biopsied and comes back as Cannon's disease. So just be familiar with the name Cannon's disease. When you think leukodemia, differential diagnosis could be Cannon's disease. So now we come to reactive lesions. Reactive lesions are anything that's induced by trauma. You have to remember trauma, we think trauma, okay, cutting, things like that. But what we can also think as trauma is tobacco use. A lot of the reactive lesions are either caused by tobacco or trauma, some sort of habit that they're doing. So that's what we look at as far as etiology. This one is extremely common. It's probably one of the most common things you will see that causes white lesions. All right. Yes. Cannon's disease is the same as white sponge nevus on the outline. Yes. Very good. All right. Frictional hyperkeratosis. On your boards, therefore on my test, I will not be that nice and call it frictional. We tend to just call it hyperkeratosis because when we use the term frictional, it's telling you the etiology. So we want to get you thinking. So that's why we all tend to just say hyperkeratosis. Hyperkeratosis is a tissue's protective response to chronic trauma. If you are going to garden every day and you're going to use shovels or some sort of little miniature shovel, whatever they call those things. I don't even, what do they call those things? The little miniature scoopers.
A trowel.
A trowel. Okay, good. Yeah. So I use shovels. I don't have any hand tools. I just like bigger holes. So if you're going to do that every day, do you think your hands are going to like it? Now, the hands will change. You may get calluses. So the mouth does the same thing. So it protects because chronic trauma. All right. What we look at is a tissue that has a rough texture. A lot of them are raised up because they're thickened tissue to protect the tissue surface. And they are white. When I use the term white, we think, okay, paper white. Well, you got to remember there's variations of white. Go to Home Depot and say you want white paint. The person behind the counter is just going to look at you like you're kidding me. Like, do you want white, off-white? There's so many whites. So there is a variation in the description of white. This is one of the common hyperkeratosis examples that you will see. Most of you all won't have, your instructors won't call it hyperkeratosis. What they're going to call it is cheek biting or chewing. All right. You'll notice how broad it is, how rough it is. It's white in texture. You have irregularity. Some areas that are white versus other areas that are white but not as thick. And this is chronic trauma. The person does this as a habit. What you can check is it bilateral? A lot of people that chew their cheeks chew both sides. Now, who of you all chew your cheeks? Do you chew one side or both sides?
Both sides.
See? I don't know. Does it taste good? I don't chew my cheeks. So I don't, I
don't realize that I'm biting them.
Oh, okay.
If my dad, if he'll see like where I make this face, he goes, "You're biting your cheeks again." It's usually just a reaction that I do.
Yeah. And it's a, you know, subconscious habit. So that is an example of hyperkeratosis. This is another thing that you will see people do, chew their tongue. The other thing that you may see, I saw a patient this week that had lost 2 crowns a couple years ago. So they basically had sharp teeth. Well, she finally decided to come in, and that chronic rubbing made a lesion. But this is a student that instead of chewing her cheeks, she liked her tongue better. And you know, ask your patient, hey, what you doing in there? In her case, it was bilateral as well. She would just kind of rotate, and you could tell she was doing something because when she would test, this is what she did as a habit. Common to see edentulous areas when the food is being chewed. We have embrasures where the food will deflect off the embrasures and kind of spread to the cheek or to the tongue so it can be recycled. Well, when you have edentulous areas, the food doesn't have the embrasure, the food packs down on the tissue. The tissue responds by thickening up because you know the person's going to traumatize because they're going to eat, all right? And now some of y'all are probably looking at this. Yes, that is rottenness in the tooth or decay. It's pretty good size. And you'll notice that the color looks bad. Well, it is. This tooth is pretty hollow. So the cavity has basically worked its way underneath the enamel, and that tooth needs to, when in doubt, take it out. This is another common hyperkeratosis. Occluding on the tissue from an opposing tooth, that chronic pounding of the tooth on the tissue knows it's not going to stop, so it thickens up. This is mixed dentition. You can see here, this is a primary tooth. What letter would that be? Oh boy, fun. Everybody's favorite, primary teeth.
Would it be K?
Ah, we're on the correct arch.
Is it T?
Yay, T, yes. Primaries are bare, aren't they? So that is letter T because tongue is over here. All right, this is quadrant 4. Now, my more favorite question, you see this tooth under here? What number is it? Oh boy.
Is it 30?
All right, 30 is a non-succedaneous tooth, so it's not going to replace a primary.
29.
29. That didn't sound definite. 29? Yeah, but yeah, that's 29. Okay, good. So 29 is a succedaneous. It will replace a primary. Good. Oh man, isn't that fun? Mm-hmm. All right. So when we talk about trauma or reactive lesion, tobacco is a source of trauma. We have something called snuff keratosis. You may also hear it called snuff dipper's patch. Different types of smokeless tobacco create different variations of this lesion. All right. Snuff tends to create this lesion versus a smokeless tobacco. Okay. If I was in class with you, I would bring smokeless tobacco and snuff and beetle nut to show you what they are. I used to have to do it hidden because we have at Guilford Tech, we had a no smoking campus wide policy. So I'd have to sneak it in a bag and, you know, make sure no one said, hey, he's bringing tobacco in. So, but it's interesting because if you've never seen it, it's kind of interesting to look at. I've tried all of them because I wanted to see what the excitement was. And I didn't find it exciting. Beetle nut. Have you all heard of beetle nut that stains the teeth? Well, let me tell you, that's some nasty stuff. I had trouble getting the woman in the store to sell it to me. I mean, we argued back and forth, back and forth. She was telling me it wasn't healthy for me. And I was like, I just want to show my students. And then that I should have never mentioned the word students because then she was really going ballistic on me. But once I got it, that stuff was worse than I don't know how they put that in their mouth. But when you look at snuff or tobacco, when it sits on that tissue, the tissue doesn't like it. The chemicals and ingredients in the tobacco irritate the tissue. Person that uses snuff or smokeless tobacco always puts it on the same side. All right. They may rotate, but they have a favorite side. Well, the tissue's going to respond. So this is an early lesion of smokeless tobacco use. You'll notice that here is a little different than here. This person puts their smokeless tobacco on the lower right. You'll notice that it's getting to be a little wrinkly or fissured. So that's how it initially starts, is it's pink and a little thickening of the tissue. So when we see larger lesions, you start to see heavier wrinkling and a more leukoplakic lesion. You'll notice that it's in the buccal mucosa of the mandibular posteriors. That's the most common area you're going to see it placed. The next common area is where I showed you on the front area. People place it always in the same area. What type? Describe the patient that uses this.
A male?
Male, younger or older?
Probably older because younger people are into like newer upcoming stuff.
Isn't that interesting? You will be seeing a trend where the younger are using a little less. Would you think sports-minded baseball players are known for this? All right. Now, I will tell you, you will find older Black females that use it. All right. So it just because you see this and you're looking at, gosh, this is an older female, they can use it as well, but that's what you should see. This is a heavier wrinkling, And it's telling you if they're using it a lot and for a long period of time, the lesion gets more noticeable. They consider this a pre-malignant lesion. Again, when we look at using tobacco, all forms of tobacco are associated with formation of oral cancer. The incidence with smokeless tobacco is not excessively high because it takes so many years of chronic use to actually form squamous cell. And you're going to find patients that have had these lesions for years, they never develop cancer. So, but it is considered pre-malignant. This is another really good example of it. They have been using it for a long period of time. Look how thick that tissue is. And when you see stuff like that, ask history of it, ask do you place anything on this tissue? And sometimes you get lucky if they used non-pouched versions of smokeless tobacco. You may even get so lucky that you see particles of the smokeless tobacco intraorally, which is really nice. This is the worst case I'd ever seen. This was a hygienist husband. That guy, instead of being normal and placing it on the in the buccal vestibule, that wad was huge that he would place inside his cheek. Well, this size lesion and the irregularity you see in here, I didn't like what I was seeing. So we referred the patient to an oral surgeon, but I don't think he ever went. It'd be interesting to see if he ever developed cancer, but that was the worst one I had ever seen. Long-term use of smokeless tobacco. We talk about oral cancer as one thing, but there's some periodontal changes and the development of dental decay. A lot of the smokeless tobaccos taste good because of the sweeteners in the product. So people that use it, you also see periodontal issues. You also see dental decay, and the patient may report, things just don't taste the same. Well, yeah, it's altered your taste. So this is a great example of the lesion. You can see the wrinkledness, but what it really shows you is how the tissue responds, thickening up on the marginal, but you also see wonderful recession. So that's one of the periodontal issues that we see is gingival recession in the area of placement. I mean, look at how the tissue looks there. It's really not bad tissue. The height, a little low here, but not too bad. The next one, you'll see recession, and you also see cervical decay. You have to think when you have that recession and you expose the cementum, it's softer. So you get root decay a lot quicker. The reason why you see the bleeding tissue, the hygiene student could not wait. She had to get going. So by the time I got in there, I couldn't get a clean picture. So I was too slow. So I had to take what I could get. But good sized cavities, not a thrill to fix either. Three friends in Germany having a wonderful time, talking about the good life and the festival that they're at. It's probably close to Oktoberfest, so that's why you see beer. One of them is so intent looking at this wonderful box she's been given. And you'll notice on the box, there is a number. So she is contestant number 90. Well, she has 1 minute to take what's in the box and place as much as she can in her nose. They take a snuff as a competition and cram as much in a 5-gram box into your nose in a minute. That's what the winner is shooting for. And then yeah, you're thinking, why? Because it's their annual festival. Hundreds of contestants come out to do this, men and women. I don't know how long it takes them to get the stuff out of their nose as well. Interesting. All right, so smoking again, nicotine stomatitis. Nicotine stomatitis is also known as smoker's palate. When we smoke cigarettes, you inhale the smoke and you get it into your lungs. When you smoke cigars, pipes, not all pipes. I guess if you're smoking marijuana pipe, you're going to inhale. But if you smoke a standard tobacco pipe, you smoke and you keep the smoke in the oral cavity. All right. When you do that, the smoke is hot. The smoke contains all the chemicals. So what that causes the tissue to do is to change. If you constantly had to put your hand close to something that was real hot, what would you want to do on your hand? You'd want to put some sort of protector. Well, that's what the mouth is doing. So they know with the chronic use of cigar smoking, all right, with the chronic use of pipe smoking, the smoke stays in the oral cavity, the heat changes the tissue, the chemicals change the tissue. So what we see is a leukoplakia on the palate. Smoking, if a smoker is a heavy cigarette smoker, you can see this. Let's say somebody smokes 2 packs of cigarettes a day. That's pretty heavy. All that smoke, heat, irritant is going to change the oral cavity. When you have a pipe smoker who smokes daily or a cigar smoker that smokes daily, the palatal tissues are getting hit with that heat and those chemicals. It thickens up to be more pale in color. So you have a generalized leukoplakic lesion. The other thing that we can see are these little dots. We used the term earlier, petechiae. Petechiae are pinpoint blood hemorrhaging. When you look at mononucleosis, the pinpoint blood hemorrhaging is taking and poking, and you have little pinpoint hemorrhages, bleeding points. This is not petechiae, but the dots are ductal inflammation. You know you have major salivary glands, the parotid, submandibular, sublingual, Stenson's duct, caruncles, and sublingual folds. Well, minor salivary glands are spread everywhere. Where the glands are under the tissue in the posterior hard palate and the soft palate, the glands are underneath the tissue, and to get the minor secretion out to keep the tissue moist, there's openings, pinholes. Well, these pinholes get irritated. We see them as inflammation. You'll also notice that the palate, the posterior palate, soft palate area is very wrinkly. This is a heavy smoker, and they are traumatizing that tissue. So what else can you tell me about this patient?
They're missing teeth.
Yes, very good. Bilaterally missing teeth. Do they wear a partial?
So say, is that's what it looks like at the maxillary?
You see this line? This is the imprint of the partial. So looking around, you see imprints like that are uniform. They go from one side to the other. It's giving you more information on the patient. But yeah, they wear a partial. So it imprints on that tissue. And a lot of the partials, if it's a metal partial, the metal has a bead. So if the partial is flat, there's a bead that imprints on the tissue, and the bead is used to kind of give more stability. So this is another example. All right, you notice this person does have a partial. All right, so it's protecting the teeth. It looks almost like the tooth that it's replacing looks gone. So they wear the partial and they don't have the tooth on the front. But the lesion, that area of the hard palate is protected by the partial, so the smoke doesn't hit there. But the hard palate is generalized leukoplakic, and you have ductal inflammation. You don't have petechiae. Okay. What structure is this?
The
Median palatal something.
Raphael, yeah, median, very good. Okay, median palatal something. Good, good. And again, this is a heavy smoker. You can tell they're really heavy because what do you know nicotine does to teeth? It stains them, right? Well, look at the staining. I mean, you see a generalized white area and you see the ductal inflammation, but this staining, man, they are heavy smokers when they start staining the white lesion brown. And nice thing about with all these lesions I'm talking here, rare that it actually creates cancers. Very, very rare that a patient will have cancer with nicotine stomatitis. All right. Solar cheilitis. Actinic is a fancy word for solar. All right. When we use the term solar, we're referring to sun exposure. All right. Solar flare is a flare on the sun. All right. So chronic sun damages tissue. All right. When you look at chronic sun exposure, the sun always beats down on the lower lip more than the upper lip. So that changes the surface of the tissue. The sun exposure, that light damage is the trauma. All right. So it's chronic. What we see is a change in the tissue surface, that the tissue becomes light in color. All right. It becomes fissured and almost what we classify as atrophic. It's losing its normal appearance. All right. So you may look at this lower lip, and in this you say, well, they need to put some lip balm on. Yeah, they do need to put some lip balm, but that chronic sun is hitting this lip and basically tormenting it. So when we see this, we tend to see it in patients that are older, fair-skinned, and most commonly associated with males. Farmers are great examples of who you will see this present in. These lesions that are on the lower lip need to be protected. If you're going to be in the sun, if you're working on the farm all day, you're not wearing a hat to protect your face, you tell a farmer, hey, I want you to put a big hat on, one of these Mexican sombreros. I ain't going to wear no Mexican sombrero on my tractor. I may wear a John Deere hat of some sort. It doesn't give as much protection. The problem with these lesions is chronic sun exposure can be cancerous a cause for cancer. All right. So that is what we look at is a pre-malignant lesion. These are other examples that you will see solar cheilitis. The bottom one here, it looks pale. They get a little fissuring. They may have bit down here because the lower lip is easier to traumatize than an upper lip, but you have to verify, did you bite your lip? This could also be telling you they have an issue with that lower lip becoming malignant. So you have to make sure if they bit their lip, I would have this patient come back to see that that heals up. Now, you may be looking at the commissures as well. This is a different lesion than what we're looking at, the atrophic lower lip. This is most likely some version of candidiasis or thrush, which we'll talk about later today. This other lip, they got a lot of problems. That does not look good. It's crusty, constantly healing. You know, and some people, when they get these little crust areas, they peel them off. Next thing you know, they got a raw area and it never heals. Well, when I look over here, that does not look good either. So if you notice that the margins are raised, maybe a crusted center, and this could be another area. These are probably basal or squamous cells. So this is not good. You know, you can tell the patient, hey, let's put some lip balm on for 2 weeks. It should help and go away. But 2 to 1, you're not going to see any change in it, or it's going to be worse. These need 2 to 1. They're going to biopsy or remove this, and they're probably going to biopsy that lower lip as well. So these are actinic or solar cheilitis. These I would venture to think they are basal cell or squamous cell. You know, basal cell, squamous cell, you can't really tell them apart unless you biopsy them. But yeah, anybody, retirees, playing tennis, you know, fair skinned, these are, you know, some issues for that person. Now, I know you're not even going to look at the lower lip because you're thinking, what the heck? Why don't they get these changed? Yeah, they should. They're a little old, to say the least. These are the composites that are easy to pick out when you're doing your charting. You're like, oh, I can tell you where these composites are. You know, this one's got an MFL. This one's got a DFL. It's the ones that are good color matches you can't see are the hard ones to identify. But when you look at this lower lip, look at this side and then look at this. It is thickened tissue, you know, and it's trying to protect itself. These white lesions that I've talked about so far, I can't wipe off. If I take gauze and try to wipe it, when I say wipe, not scrub it like sandpaper, just wipe it. If it's still there, it's telling you the tissue has changed on the surface. Okay. All right. So let's take our break and we'll go from there. All right. We will go ahead and start back. So we're going to look at some other white lesions, and these have a variety of etiologies, more so fungus, virus type scenarios. All right, the first one is something called heroleucoplakia. Heroleucoplakia is a lesion that's caused by 2 possible things. One, it's definitely caused by Epstein-Barr virus. The Epstein-Barr virus, you know, we talked about with mononucleosis, but when these lesions are biopsied, A lot of them also have Candida albicans, which we'll talk about shortly. Candida albicans is a fungus. So you have a mixed viral fungus type lesion. The majority of hair leukoplakia, we always tend to associate it with HIV. Patients, as they are being diagnosed as having AIDS, hair leukoplakia is one of the indicator diseases that something is going from HIV and being diagnosed as having AIDS. So that's what we tend to see HL or hair leukoplakia in. There has been some documented cases where non-AIDS patients have had it, but it's very few and far between. So when we look at this, we have, all right, an HIV positive patient. They're going to have other findings as well. These lesions occur on the lateral borders of the tongue. They have varied appearances. A lot of them are corrugated, and some of them are also what we call plaque-like. These lesions do not wipe off. It's a change in the tissue surface. They are diagnosed as HL by biopsy, but also remember that you will have other findings in these patients because they are diagnosed with AIDS. The lesions, where you see them is where you see them. Some of them can get quite large in size, and they can actually grow to the ventral surface of the tongue. So something like this, when we use the term corrugated, if you've ever seen cardboard, you have the outer and the inner layer, or the two outer layers, but the corrugations look like this. Well, that's what that top lesion here looks like. It has a corrugated look. So that's what we see. These are some other variations of it. These are more plaque-like in nature. And again, you take a 2x2 gauze, you wipe it off. Does not wipe off. Most of these are bilateral in nature, but once in a while you can find a unilateral as well. So the main thing we want to focus on is hair leukoplakia is found in those being diagnosed with AIDS. So they have a lot of other findings going on. Okay. All right. This is something that you will see probably almost every day when you're out in private practice. Hairy tongue is classified as an overgrowth of the filiform papilla. If you look at the papilla on the dorsal surface of the tongue, the one that gives it the carpet-like appearance, those are your filiform papilla. Those do not have taste buds. They're the most numerous that we have. Well, those filiform papilla actually grow, and some of them can get quite large. Most of the time we see it as a slight growth with a discoloration. We're not sure why it happens, but the majority of them are definitely associated with people not brushing their tongue. So when we don't brush our tongue, we don't denude or take off the old layers. So that's why we see it. There's some predisposing factors that make this condition appear. People that take antibiotics, it tends to pop up. It also tends to change the color of the tongue. So when you see discolored dorsal surfaces, you can ask the patient, are you taking anything? Do you use inhalers? Do you, any kind of recent infections that they gave you any kind of antibiotics? So antibiotics are a big one. Taking a steroid is another big one that you can see. Oxidizing agents. Some people rinse their mouth out with hydrogen peroxide. Years ago, we used to tell them do it all the time. Well, hydrogen peroxide in daily or chronic use is actually not good for you. Hydrogen peroxide creates what we call oxidizing agents. They will make the surface of the tongue turn white in color. Smoking can do it. Smoking is easy to see hairy tongue because it changes the color of the tongue. Radiation treatment, Candida albicans can also create this as well. When we see it on the tongue, a lot of times we can wipe it off, but most of the time with the Candida albicans, it actually embeds in those papilla. When you're sick, next time you're sick, look at your tongue. Your tongue does all kind of weird things when you're sick. Xerostomia is another thing that you can see hairy tongue in. So you're going to notice that when I show you hairy tongue, it has a lot of different colors to it. The hairy tongue on the top, this one, this person is probably using some sort of peroxide or oxidizing agent. The filiform papilla, you know, should be pink in color. Well, when they get bigger or slightly tall, it's not like saying they're growing mohawks, but they will grow and give a little extra length to it. Well, they're easy to discolor. The one that you see down here that is discolored, but look at these filiform papilla. They look different than these here. These are taller. They almost become like shag carpet. This here is probably a little bit of geographic tongue in there, but they may be a smoker and they can actually discolor it. And the easy way to get rid of this stuff is brushing your tongue to help exfoliate, just like washing your face or skin. Hairy tongue here. You can see, you know, filiform papilla are a little larger. They kind of almost look like they're getting hairy. Heavy smokers, you also see it way in the back there on that posterior aspect. This is an interesting color. A lot of times antibiotics really give you some strange colors in there. A little more hairy over on this side that you can see. So they're probably a smoker that has been on a recent bout of antibiotics and they're not brushing their tongue. So that's what we kind of see with hairy tongue. The one here is a student that just finished up a Z-Pak antibiotic, and you can see how it discolored their tongue, slightly excessive growth of the filiform papilla. Nice in the fissuring, you can see the filiform papilla have really thickened. That's because they've grown. And again, heavy smoker. You can also tell by how much they smoke and where they place their cigarette between 8 and 9. It has discolored those teeth. This is really big hairy tongue. That's big hair. I have a CD, but it's actually called a laser disc. It's about this big. They used to watch movies, but I have a picture of a hairy tongue on there that is sitting up. They grew in the midline a good ½ inch filiform papilla. You can almost comb it over to one side or the other. So large. Interesting thing about hairy tongue, you can discolor the color of your tongue by what you're eating. It's interesting when you see kids, they come in with all kind of strange colors. You ask them what the heck you ate beforehand. They eat some weird things and you see some weird colors. And then if you're really fortunate, you drive them down the road, you see hairy tongue on a car. Not too often, but once in a while, which is really kind of interesting. They have a Toyota symbol, but a Honda car. I think they'd want to mix the two together. Who knows? Geographic tongue, another very common condition you will see. Geographic tongue is also called benign migratory glossitis. Glossitis is inflammation of the tongue. it's benign, even though some of these conditions, you look at them and you're like, oh my gosh, that's horrible looking. It's a benign condition. It just happens. Nothing cancerous about it. The reason why we call it migratory, this lesion migrates or moves. You can't watch it move, but you may, if you have it, you look at your tongue, and next thing you know, the pattern has moved. Well, that's what it does. It kind of moves around. Not sure why it happens, but it seems to be more common in females than males. When we look at it, interesting thing, people that have geographic tongue, a lot of them have fissured tongue. And this, you'll notice the fissuring down here. The geographic tongue is over here. And look at the size of this fissure. And a lot of fissuring over here. So those go hand in hand. They are, if you have fissured tongue or geographic tongue, you have a high chance of having fissured tongue. Fissured tongue, you have a higher chance of having geographic tongue. People that have psoriasis, psoriasis kind of looks like geographic tongue under a microscope. But if you have psoriasis, you have 5 times the chance of having geographic tongue. They've had studies, they mimic one another. One's outside, one's inside. But for some odd reason, psoriasis has a higher incidence of it. Smokers. When you look at smoking does a lot of strange things. It's basically what we consider a inverse relationship. If you smoke, you have less of a chance of having geographic tongue. So it's almost like the aphthous ulcer. If you smoke, you don't have aphthous ulcers, all right? So inverse relationship. So this is what geographic tongue looks like. It actually, it has lots of different appearances, but this is one example. Geographic tongue is different than hairy tongue. Hairy tongue is the growth of the filiform papilla. Geographic tongue is the reduction of the filiform papilla. So they probably have hairy tongue here because they're longer, and then they have geographic, a little balding here. You'll notice it can become very patchwork, very unique patterns, to say the least. The patterns, I wish I would have taken pictures of every geographic tongue I've ever seen, because it'd make a great show and tell book, because the patterns are really weird. You can see that this one here, hairy tongue, and a lot of big patchwork. Some of them are what they call cauliflower. I don't know where they get the term, but you'll see the raised ridges. It's almost like the filiform papilla grew on those ridges, and where it's red is the loss of the filiform papilla. Interesting pattern, okay? So loss of filiform, growth of filiform around the periphery, all right? Strange pattern, and you see a lot of fissuring. Now, I know some of you all have to have geographic tongue. Yeah? So when does it occur? When do you get it? Do you eat something in particular? Some people will tell you they eat something, next thing they know, they get it. Stress can do it. Monthly menstruation cycles can do it as well. So it's a normal thing. It's just something cool to say. Some of the different patterns that you say are these strange little cauliflower type lesions. Okay, so you can definitely see it. Now, you may see one little lesion, and that's geographic tongue on that person. We tend to see it on the lateral borders to the dorsal surface. But there's something called stomatitis areata migrans. Stomatitis areata migrans is what we call ectopic geographic tongue. The term ectopic is abnormally placed, so it's abnormally placed geographic tongue. We expect geographic tongue to be on the dorsal surface because that's where the filiform papilla are. But when you see it on the ventral surface, you see the cauliflower shapes, all right? Those are what we see as ectopic geographic tongue. You can even see stomatitis areata migrans or ectopic geographic tongue in the cheek. It looks exactly what you would think it would look like on the dorsal surface, but you can see it on the cheek. This is a ex-military dental assistant. She knew exactly what she had, but really impressive geographic tongue. And she also had it in her cheeks. People that get this do say their tongue gets a little tender because when you have the balding of those filiform papilla, it's a little more raw. So they don't like to drink acidic type things, orange juice, that kind of stuff. This is another common thing. You know, when I started looking at lesions intraorally, I mean, we saw this here and there, but now you see this everywhere. I mean, it's just a common finding. Lichen planus is an interesting mucocutaneous disease process that we really don't know what the etiology is. They think it's autoimmune. If they, you know, the rule of thumb is if you can't guess, it's got to be autoimmune. But it almost mimics a hypersensitivity reaction, like an allergic reaction intraorally, but they also get skin lesions. So we use the term mucocutaneous because they have skin and mucous membranes. Where we see it heavily in the mucous membrane category, much more than the skin, but dermatologists see it all the time skin-wise, and I'm assuming they look intraoral. So lichen planus, there are different versions of lichen planus. We have reticular, plaque-like, atrophic, and atrophic is telling you you're having loss of tissue surface, erosive, basically erosions or ulcers, and bullous. The most common ones are the reticular. You will also see a good amount of plaque and a good amount of erosive. So the variations, when we look at the variations, what we consider the classic lesion with lichen planus is something called Wickham's striae. Wickham's striae, we always associate with the reticular form. So if you ask any of your instructors, all right, tell me about the lesion with lichen planus, they're going to tell you Wickham's striae. That's by far the most common. All right. It has what we call a lace-like pattern. If you know what a doily is, I'm assuming some of you know what a doily is. Some of you may like a doily. What is it? I don't know what a doily is. Well, I'm sure you do. These are doilies. You may sit there and say, that's what they have. My grandmother has one. My grandmother made it. Well, doilies have a very lace-like pattern. So they resemble the lesion of Wickham striae. This is what you see as far as a patient with reticular form of lichen planus. These are Wickham striae. You'll notice that it looks like a doily. You have interlocking or lace-like pattern. Very characteristic for this disease process. The most common area you're going to see it bilaterally on the buccal mucosa. You can see it elsewhere. I've seen it on the side of the tongue, but look at the patient's cheek. And if you see it on one side, look at the other, and you'll most likely see it there as well. These are another example of Wickham striae. Huge lace-like pattern that you see the rings interlocking, right? One of the things that you also noticed, you notice this up here. Does that look normal to you? Or does it look a little raw? A little raw. And one of the things with lichen planus, if you see Wickham striae, there is a high probability you are going to see another variation intraorally. So this is an example of, you can see some of the Wickham striae in this area, but you notice it starts getting heavier. They're not as fine laced. This is picking up a second variation, the plaque form. So lichen planus tends to present with two different findings at the same time. Nice colored teeth, don't you think? So we see Wickham striae, all right, not as many, but a heavier plaque version of lichen planus. And then this one's got some nice Wickham striae. This is a great area to look at here, but look at this erosion. So, you know, could this be two aphthous ulcers? Yeah, it could be, but most likely it is two forms of lichen planus, reticular and erosive. When you start seeing erosion versions, it tends to be found more in those that are high stressed. The common patient that we see lichen planus in are females. The more erosive that you see, the more stressed they are, or they have some sort of psychological component associated with it. This here is an erosive form. You can probably see a little bit of plaque form here, but the tissues just look denuded or stripped. And this is going to be more generalized in appearance. So you kind of look around at all four quadrants and see what's going on. Y'all probably like to use the term sextants. Hygienists tend to use the term sextants. Dentists tend to use the word quadrants. They probably, is that true what they teach you all, more sextants? If I'm correct? No, they teach quadrants? Okay, well, good. Hygienists always seem like sextants. I don't know. If I was teaching you all in the clinic, I would sometimes make you take pictures. This student wanted credit. So she said, well, if you show by picture, I want credit. So her name was Paris. You'll notice the redness and look at the plaque formation. So multiple types in that patient. And you can probably also notice on the tongue, you can get lichen planus on the tongue as well. Erosive, you know, a lot of times we see it at the gingival as well. One of the things that we were telling you was lichen planus is a mucocutaneous disease process. Mucous membranes, skin. If you see a patient with lichen planus intraorally, take a look at their hands and their wrist. A lot of the patients, if they have erosive intraorally, they're going to have cutaneous lesions as well. And then you could always ask them, hey, you got any kind of sores or rashes or anything going on anywhere else on your body? The most common areas we see are forearms, wrist, hands. So it's, and tends to be more with erosive than the Wickham striae. All right, candidiasis. fungus among us. So when we look at candidiasis, some of you all are probably familiar with the term thrush. An older term is monoliasis. They're referring to the same type of condition. Candidiasis is an opportunistic fungal or mycotic infection. All of you have Candida albicans in your mouth. All of you have this fungus in your mouth, all right? We don't see the fungus because bacteria in the mouth keep it in line. The bacteria say, hey, you're not going to be showing your self around this mouth because I'm going to make sure you don't show. When the bacteria that keep the fungus in check are knocked off, all right, we take an antibiotic example, the fungus grows. So when we see candidiasis, we consider it opportunistic, meaning when an opportunity arises, the fungus presents or shows clinically. All right. We also consider candidiasis a disease of the diseased. The reason why we say a disease of the diseased, candidiasis is a disease in itself. When you become sick, this is when it shows. So the diagnosis is candidiasis. The etiology is an overgrowth of Candida albicans. It's tricky, those ways of putting it, don't you think? Etiology versus condition. Okay, so Candida albicans is a fungus that presents when opportunities arise. When it arises, one of the things it can produce is a condition called candidiasis. So why do some people, or why does candidiasis appear in some? We look at age is one reason why. Infants are known to have thrush. Their immune system is not fully functioning. So this opportunistic fungal infection presents. We also look at age-wise, elderly. Elderly also have immune systems that don't function as well as they should. So opportunity arises, Candida albicans has an overgrowth. Other conditions that you're going to see, if you take antibiotics, antibiotics are a medication that basically kill or inhibit the growth of bacteria. If we take antibiotics to get rid of a bacterial infection, good bacteria and bad bacteria are killed or inhibited. By doing that, Candida albicans can grow. All right. So we used to give a lot of antibiotic pre-medication for a patient if they had a condition that they needed antibiotic pre-meds. Females especially did not like us as dentists because the antibiotics would kill bacteria. Next thing you know, they had a fungal outbreak. And when we look at a fungal outbreak, the fungus can also occur vaginally. It's the same type of fungus. Endocrine issues, again, they're sick, diabetics, things like that, they can get it. Malignancies, patients that have cancers can get it. If they get chemo or radiation treatment, they can get it. People that use bronchodilators or inhalers, they can get it as well. All right. When we look at dietary deficiencies, you can get it. If you have vitamin deficiencies, your oral cavity really will show deficiencies very well. When we talk about indicators of becoming diagnosed with AIDS, candidiasis is one of the indicators. Most of the time, candidiasis is not really generalized. It can be, but in patients with AIDS, their candidiasis is extensive. They actually get candidiasis down their throat. That's how involved it is. When we look at candidiasis, there's various forms. There is actually red versions of it, which are very uncommon. There's also what we call hyperplastic, where the candidiasis embeds in the tissue. That's less common. The most common, whenever you tell somebody, all right, or ask them, tell me about candidiasis, they're going to tell you it's a white lesion. All right. What they're referring to is acute pseudomembranous. That's the acute pseudomembranous form of candidiasis. That is by far the most common version that we see. So this is an example of the most common, the acute pseudomembranous form. This on the palate, they may use an inhaler. Well, this white lesion, when we talked about why are white lesions formed, that is all fungus. So that's Candida albicans. We will take gauze, and how we diagnose this is we take gauze, we wipe it across the surface. When you do that, your gauze is going to have a lot of the fungus. What you see left is raw red tissue, because you've almost, think about if you stripped a blister off, you would have that tissue. Well, you had fungus on the surface. You've taken that away. The surface is now irritated and red. Lower lip, same thing. You can wipe that off and there you go. I actually saw a case of this last week in a patient, and I took a before and after, wipe and not. Pretty neat to see. You'll see that they are white. They can occur anywhere they want. Some of them, like this one, starts picking up a yellow tint to it. But when you see this, you have to ask the patient about what's going on. Or if it's a very young child, an infant, you know, their immune system is not up to par. Same thing with the elderly. See if they have a disease condition that is going on. This one here is really thick, but it's just telling you that's a lot of fungus. When you wipe that off, if you actually had a microscope, you could wipe that off, put it under the microscope, and you would see little, what we call hyphae. They're almost like little flat fungal tree trunks. Very common to see them under dentures. Does the same thing. When you have a denture, the denture fits over, and if it has a little bit of a gap in between the denture and the ridge, it gives a space for the fungus to grow. Under the denture, it is dark, it is moist, it is warm. That's what stimulates the growth of Candida albicans. This one's got really nice color. Illness could definitely do it. Looks like their tonsils are enlarged. But yeah, and their uvula. So pretty nasty one. How you get rid of them is antifungals. Fungus are hard to get rid of. If you've ever had like athlete's foot, It's a tough fungus to get rid of. And the last one we talk about is something called angular cheilitis. Angular cheilitis is a form of candidiasis. It's a specific form that occurs in the corners of the mouth, so at the commissures. One of the things with angular cheilitis, if you take a sample of it, a lot of times you also find Staph aureus. Staph aureus is a nasal bacteria. So they're close to one another, and Staph aureus can get mixed in the angular cheilitis. But, you know, most of the time people are just going to treat the angular cheilitis and not think about the Staph aureus. How we know Staph aureus is present is the color typically is more associated with a brown type color. So what causes angular cheilitis? Angular cheilitis, the most common thing you're going to see is what we call decreased vertical dimension. You all have seen pictures of people that don't have teeth and don't wear dentures. You notice how their face is scrunched closed? Well, when their face is more scrunched, this decreases the vertical. So when I tell you to bite your teeth together, I could put a dot here and here, and I measure a distance. Everybody has a distance. We call that vertical dimension. If I take out all your teeth, that distance will decrease because that's just your muscles pulling up your lower jaw. So when somebody's missing teeth, have worn down their teeth, or are wearing dentures that the teeth are flattened out, that's decreased vertical. When you decrease your vertical, your lips overlap one another, and that creates a dark, moist, warm environment. Fungus grows. Also, people that constantly lick the corners of their mouth, they keep licking like that. Well, 2 to 1, they're licking because it's chronically sore, because the fungus is there. Vitamin deficiency is riboflavin. Vitamin B2 is associated with it as well. So if you see this and the vertical dimension looks good, you know, it could be a vitamin deficiency. Trauma can also do this. You traumatize the corners of your mouth, and fungus get a chance to outgrow in that area. So these are examples of angular cheilitis. If you look here and here, you can see a change in the commissure. Now you're thinking, gosh, their whole lip looks kind of nasty. Yeah, it is. They have a vitamin deficiency, and that's another thing that we can see with vitamin deficiencies is multiple findings or changes in the oral cavity. I would also look at their tongue. We're going to learn about red lesions. Their tongue is going to change with vitamin deficiencies. So we look in here and look at the commissures. Commissures are white in color. All right. This is your angular cheilitis, little cracking. All right. We can also see the color of their tongue is a little altered. So is it over here? This could be just lighting. So the question is, do they have candidiasis on the tongue as well? So, you know, if it's white, you wipe it and see what it does. Angular cheilitis, when you get that white areas up here with that fungus, a lot of times the fungus is wiped off quite easily, and you leave these raw areas here. Trauma can do it as well. Y'all are going to learn to take impressions on one another. Say if you're making bleaching trays, I've seen students take too big of a tray in a too small of a mouth and actually rip the corners or the commissures. trying to cram that tray in. So you can traumatize it, but that's a common appearance when you have the cracking associated with angular cheilitis. They got a lot of stuff going on. You'll notice that this is definitely different than it should be. A lot of cracking and dried skin up there, but their tongue looks a little funky as well. So they have the angular cheilitis, but they also have candidiasis embedded in their tongue, the outer surfaces. That's a hyperplastic version. That one, unfortunately, does not wipe off. But the main thing in there is just showing you that angular cheilitis. This is not my cat, but it's a good one to close white lesions with. I don't think my cat, well, actually, I think one of my cats would sit in there as long as it wasn't on the stove. All right. You all are good. If you, when you start seeing, wait a minute, what's today? So you start seeing patients next Tuesday, Wednesday?
Monday.
Oh, Monday. Oh, exciting. I won't be sleeping Sunday night. Okay. When you start looking at your patients, start thinking about, hey, can I use something for my assignment? If you happen not to find anything, I'm going to give you a third or a second option. So no big stress. I'm going to open up the second case assignment. It will be similar to the first one we did where we described something. I think I have it on a white lesion. So quick and easy for you. You can do it whenever, you know, you got time to do it, but some of y'all like to burn that stuff out as soon as you get it. So that's fine. Okay. Well, good luck on your patients. Hopefully you'll see some interesting things and everything will go nice and smooth for you. All right. Y'all are all set. I'll see you next week.
We do not have your class next Friday,
no.
right?
Oh, darn. Yes, that's right. I'll see you in 2 weeks. I forgot all about that. I'm glad you reminded me. I'd be sitting here thinking, where is everybody? Actually, I wouldn't, but that's okay. Nope. So I'll see you all in 2 weeks.
Thank you.
Bye,
All
thank
right.
you.
Bye-bye.
Bye. Thank you.